This is the question I have for you that I want to answer. What is implementation science and why does it matter for maternal care and outcomes? And I teach implementation science. I've taught a certificate program and all sorts of courses, and I can tell you it confuses a lot of people. How many of you have heard of the phrase implementation science? It's a lot of people by now. How many of you feel like you have a good handle on what it is? Many fewer hands, right? So I'm not going to lecture at you about what it is, but I want to give you a 3 to 5 minute primer on implementation science, and then I'm actually going to invite our panelists up, and I'm going to ask them questions that are relevant to implementation science. And the reason it matters is that, as Elliot mentioned, we have a last mile problem. We know what we ought to be doing to improve maternal health. We have so many examples of seeing that work done well, and yet we still struggle to implement, to see these interventions actually deployed at the level of patient care to improve outcomes at the bedside. So implementation science is all about that last mile and figuring out how to bridge evidence to practice gaps. So the one thing I want to share with you is the implementation science subway, which is a sort of shorthand way of thinking about implementation science that I developed with some colleagues. And I'm going to walk you through what this subway is. We developed it as an accessible way to sort of get people into understanding what this is. There's a QR code in the lower left corner. If you want to scan that, you'll have access to the paper, which is open access. So what we're doing in implementation science is we're trying to bridge evidence to practice gaps. We know what we ought to do, and we know that we don't do it. So how do we bridge that? So the first thing we have people do is to identify their practice of interest. Classically, it's something that has strong evidence. What we've learned in maternal health is that for many reasons that were elucidated already, the quality of the evidence we have is a little dicey. So we do what we can, we identify the practices that we think have promise, and then we move forward. And the first stop on the subway, hopefully many of you have taken a metro or a subway, so this looks a little bit familiar. The first stop on the subway is we ask ourselves, has the practice of interest shown efficacy? In an ideal setting, it could be a randomized controlled trial, it could be a lab study. From a mechanistic perspective, does it work? Does giving people IV iron who are anemic improve their hemoglobin? Yeah, that works, right? That works. There are other interventions where we're not sure if it works. So if we don't know if it works, we actually have to do that. We do efficacy research. That's not implementation science. We want people to design for implementation. I guess I'm done. No. We want people to think about implementation as they're designing their interventions. And this has been one of the topics of discussion that I've had with some of our industry partners as we've talked, is think about that from the inception. So an example I give, if you think about antibiotics, let's say you're going to design a new antibiotic. Don't design an antibiotic that needs to be delivered 6 times a day, because we're not going to do it right. Don't design a technology that is so complicated that it completely disrupts workflow, no one's going to use it. So as you design your interventions, you want to think about implementation, but that's not implementation science. So let's say you have a practice of interest that has in fact shown efficacy. We know that at a mechanistic level it works. The next stop on the subway is to ask ourselves, has it shown effectiveness? So in the real world, with all of the alarms and the multiple patients you're taking care of and all of the things that are going on, does it still work? And if we don't know, then you can do effectiveness research, and we're used to seeing that. Increasingly, we see people look at implementation and effectiveness at the same time. So we're asking questions. We think it'll work, but let's look to see whether it works, but also let's ask ourselves how to get people to do the thing. And so that's what you'll see in that rib that says no or partial, where we're doing trials that include outcomes related to effectiveness, like morbidity and mortality, but we're also looking at implementation outcomes, like are people doing it? How much does it cost? What are the things that get in the way of people doing it? But sometimes we know for sure that it works in the real world, and we're still not doing it. And that's where we thrive as implementation scientists. Like, why aren't people washing their hands? We know that hand washing works. Semmelweis did that work a long, long time ago, right? But people still aren't washing their hands. Then we want to know, what are the contextual factors that influence whether people are adhering to the evidence-based practice? We design implementation strategies to get them to do it, and then we test those implementation strategies. So everything in the lower right corner is implementation science. It's a behavioral science that helps us understand how to get people and places and institutions to do the things that we want them to do.